Hello again. So this is the last lecture before the study break. We are now starting on our musculoskeletal system, and the content for this lecture is we look at bones and cartilage to start off with, then how bones get regulated, remodeled, and how they repair themselves, and then we look at some parts of the skeleton. So we're well and truly now in our organ systems. So unlike the immune system that we looked at in topic 3 last week, which was more a functional organ system, the musculoskeletal is a proper organ system made up of different tissues that form various organs. And in our case, the organs are either the bones or the muscles themselves. Now we're going to cover 2 chapters. Chapter 6, we look at cartilage, types of cartilage we have, which is kind of revisiting what we already did when we looked at the tissues, like connective tissues. We look at the functions of bones, how are they classified, bone structure, how they develop, remodel and repair, and we won't go into any of those things there. Then the next chapter, 7, we will look at the skeleton. Now I don't look at the whole skeleton as such because this is going to be far too comprehensive. You don't really need to know all the nitty-gritty bits of every single bone in the skeleton. You need to have an idea of pretty much the most important bones and what are they called. And then we will specifically look at the vertebral column and the thoracic cage and the pelvis, as these play quite a big role in various clinical areas, and we use a lot of those bone structures for landmarks to find spots where we put injections, for example, or we attach ECG. Okay, to start off with, cartilage. So we already know that there are 3 types of cartilage: hyaline, elastic and fibrous. So they are marked here on this figure in different colors, and they are part of the connective tissue. If you remember, that was one type of connective tissue. And the hyaline cartilage, which is marked in blue on here, provides a lot of flexibility and resilience. It's very common all over the body. And remember, we had a sample of that, like a tissue slide of the trachea in our week 4 tutorial. And as you can see, hyaline cartilage really is in a lot of areas of the body. It covers all our joint surfaces. Also is a major player in the rib cage. And we do have cartilage in the nose. Part of it is bone, part of it is nose, and you can feel that when you wriggle your nose. You can see where the bone ends and the cartilage starts. So that's also hyaline cartilage. Elastic cartilage, much more stretchy, and we only have 2 areas in the body where we have that, which is the ear and the epiglottis. The epiglottis is the lid of our larynx. Larynx, also known as the voice box. The epiglottis, very importantly, has to close off when we're eating, so that we don't get food into our trachea and the bronchi and therefore the lungs. So the epiglottis, a very, very important little structure, and can cause problems, particularly in older age, where that mechanism or that whole sequence of how the epiglottis closes while we're chewing and swallowing and eating doesn't work as well anymore, which is why people aspirate, they get food into their lungs. So the epiglottis, very important little structure. The fibrous cartilage is very compressible and very strong, which is why we have it in areas where we have a lot of pressure on the skeleton. So our spinal column, our knee joints, and also the pubic symphysis. Now, cartilage usually stops growing once in adolescence, so once the skeleton stops growing. So a lot of cartilage growth during, well, even in utero when we're embryo and fetus, and then of course all through childhood and adolescence, cartilage grows but stops growing when our skeleton growth stops as well. So there is a myth that ears and noses continue to grow as we age, but it's just that, it's a myth. Ears and noses do get bigger, but that is due to drooping. When we age, the collagen and elastin fibers that make up the cartilage, they begin to break down. So that causes them to sag and stretch, and it just all appears longer. And additionally, our skin that usually provides support, structural support to cartilage, it also contains collagen and elastic fibers and droops as well over time, as we know. So that just compounds the whole problem. So no, cartilage doesn't continue to grow in age, it's just sagging. So it might help you in one of the quiz nights, might be a question. The function of bones and skeleton. So first of all, obviously our skeleton provides the shape for our body, and it provides a lot of protection. Think of the rib cage and the skull, and obviously is the support for all our body organs. It's like a scaffolding of all our body. It acts as an anchorage for muscle attachment, and it's the site of where our blood cells, the red blood cells and the white blood cells, get formed, and we call that process hematopoiesis. So a very important role of the bone there, and we'll talk about that a little bit later as well. Mineral storage, particularly calcium and phosphate, and again we'll talk about that a little bit later. Also fat storage, so apart from our adipose tissue, we can have quite a bit of fat stored in our bones, particularly in the yellow bone marrow, and it's formed in the shape of triglycerides, one of the small molecules, one of the building blocks for lipids. Now our bones also, like some of the cells in there, produce osteocalcin, which is a hormone that is involved in the regulation of insulin secretion, and we'll talk about that more when we discuss the endocrine system. We have 206 bones in the body. We'll start off with about 270 to 300 at birth, and we call them axial or appendicular. So axial, our spinal column, the skull and the thorax, and appendicular is the pelvis and our arms and legs, so upper and lower extremities. We have two types of bone: compact, also called cortical bone, or spongy or cancellous bone, or trabecular bone it's sometimes called as well, and we'll discuss that in a bit more detail in a tick. So the spongy bone, or the compact bone, usually the dense outer layer of our bones, whereas the spongy bone is like a honeycomb structure. It's called trabecular bone because it has these little spiny processes that, which we'll see when you see the figure, and they're filled with either red or yellow marrow. We also have some membranes in the bone, the periosteum, which is around the lining of the outside of our compact bone, and the endoosteum, which lines the inside of our compact bone, but also lines all the trabeculae and all the perforating canals. And again, we'll see that in a figure a few slides down. I've already mentioned what the axial and the appendicular skeleton is. Now we have different shapes of bones, so they get classified either as long, flat, short, or irregular. So our long bones are pretty much all our appendicular bones, except the patella, the kneecap, and the wrist and ankle bones. And we looked at some of those even in week 1. You could see those little bones in the wrist and the ankle. So they come under our short bones because they're like short little fat ones, or cuboidal bones, so cube-like shape. Then the flat bones are our ribs and the scapula. And irregular bones are pretty much anything else that doesn't fall into any of the other categories. So all our facial bones, because they're like really bizarre, and also the skull, our vertebrae, and our hip bones. Okay, I promised you a figure, and here it is. So let's look at the components or the structures of the bone and some of the terminology that we have. So in figure A, we can see a long bone. In B, we see an enlargement here of some of those parts. So we can see a bit of the compact bone on the outside here, but then also the spongy bone. So an enlargement of one of these areas. Figure C shows the enlargement of the middle part of the bone, or the diaphysis. Okay, so let's start off with the diaphysis or diaphysis, which is the shaft of the long bone. And you can see that it has a cavity, which we call the medullary cavity, which is lined by endosteum. And you can see that all around the bone we have our periosteum, apart from where the bone articulates with another bone. That's covered by articular cartilage, which is usually hyaline cartilage. We also have the ends of the bone, which are called the epiphysis. So it's on top of the bone. And we have the one that's distal from the center of the body and more proximal, closer to the center of the body. We also have, that you can see here, the epiphyseal line, and I'll talk about that later on, what that is. So this is an adult bone because it has an epiphyseal line. If it was an adolescent or a child's bone, instead of the line, we'd have cartilage here. So we'd have the epiphyseal plate instead. So membranes, I've already talked about periosteum and endosteum lining all the inside structures, and you can see it's not just the compact bone that gets lined with the endosteum, it's every little trabeculae that is lined with the endosteum as well, so it reaches all the way inside. The periosteum that's around our bone also contains osteoprogenitor cells, which can turn into osteoblasts and produce bone, and osteoclasts, which are the ones that destroy bone. Now we also have blood vessels and nerve. So remember, we said previously bone tissue is innervated and very vascular, as you can see here. Now whilst this only shows the nutrient artery, there's also of course veins, and then of course we've got nerves going into the bone as well. One thing important to know is that the red bone marrow initially is in all the medullary cavities and in all the spongy bone. So when we're children, we have it everywhere. We have red bone marrow. As adults, most of that gets replaced by yellow bone marrow, and the only red bone marrow that we have left is in the head of the humerus, so the upper arm bone, the head of the femur, which is our thigh bone, and in the flat bones, so the skull, the sternum, the ribs, clavicle, scapula, and hip bones, and our vertebrae. All the other areas, like I said, are replaced by yellow bone marrow, as you can see here. So if you look at the shaft in more detail, you can see this big blob of yellow bone marrow storing fat in the form of triglycerides. We've got compact bone around, because this is the shaft, so we don't actually have spongy bone. The spongy bone is more towards the epiphysis. We've got our periosteum, and again you can see here that the periosteum has an inner and an outer layer, so one that's more on the outside and one that's close to the bone, and it's anchored to the bone by those perforating fibers. So now we look at our cells that are part of the bone tissue, and we already said that when we looked at the tissues, that they are called osteoblasts and osteoclasts. So they derive from, well, the osteoblasts derive from these osteoprogenitor cells, which are like a precursor, like a stem cell. So they turn into osteoblasts, and osteoblasts are specialized fibroblasts, so they can make fibers. In this case they make collagen fibers for the bone. They also produce a ground substance, which in this case we call non-mineralized bone matrix, or osteoid. So remember, every connective tissue produces ground substance. So in this case we have a non-mineralized bone matrix, or also called osteoid. Those osteoblasts can also produce that hormone that I mentioned, the osteocalcin. They can turn into what's called lining cells, so they're kind of covering the bone surfaces. They don't do very much, they just sit there. They also respond to parathyroid hormone, as we will see soon, and do something when they get stimulated by that hormone. And they turn into osteocytes once those osteons form, and we will see that in a tick, how that works, where they basically get embedded into the calcified bone matrix. So initially we start off with non-mineralized or non-calcified bone matrix, which eventually becomes calcified or mineralized, and that's when the osteoblasts turn into osteocytes. So they just sit there. They can basically monitor what's going on with the bone, so they kind of sense if there's additional stress on the bone, and then they can trigger more bone growth and bone remodeling. Now separate, these guys here, the osteoclasts, they don't derive from those osteoprogenitor cells, only the osteoblasts do. These guys come from a different lineage. They're more like a white blood cell, a bit like our macrophages, so it comes from that kind of line. And as you can see, it's multinucleated. It's got lots of nuclei. Got a very funny shape because it phagocyte. It's like a phagocyte, so it eats up bone matrix and can also eat up osteoblasts. Now the osteoclasts, they also contain digestive enzymes, obviously, like lysosomes, so they can digest whatever they gobble up. And the other thing to know is that these guys here, the osteocytes, they're very similar to the chondrocytes. They live in little indents called lacunae, so same as in the chondrocytes. And the mineralization process occurs by forming calcium and phosphate salts, and these calcium and phosphate salts will then be arranged as little crystals around the collagen fibers. So this is the reason why, and which is pretty much inorganic material then. So the fibers are still alive and our cells are alive, but 65% of our bone mass are the mineralized parts, or the calcium phosphate salts, and they last well beyond death. So that's why you can still find skeletons, but there is no other tissue present. So now we look into more detail into the functional units of the bone. So just going back to this here, we now kind of look at this part here, but in even bigger. So we just see a part of the compact bone, and you can see that the compact bone is made up, as you can see here, it's like a little bit of that shaft here of that compact bone is made up of something that's called an osteon, or a Haversian system. Again, you know, named after someone who discovered it. That guy must have been called Havers. I'm sure he was German. No, I don't know. So anyway, that little osteon contains of a vein, an artery and a nerve, and around it it's got these lamellae, which are basically hollow tubes made up of calcified or mineralized bone matrix with osteocytes interspersed in it. So you can see those little osteocytes here. that got their little extensions, and they're also linked up with these little canaliculi, which links them up together, but also across the different lamellae. Now the other trick with those lamellae is that they contain collagen fibers, and in this layer the collagen fibers might go that way. In this lamellae the collagen fibers might go that way. In this one they might go more diagonal, so they go in different directions from lamella to lamella, which that really is what gives bone its incredible strength, and you can't bend it easily. Now what else do we need to know? Oh, we've got the osteocytes, we've got our artery and vein and nerve. We've also got, so these run in these, what's called the canal, the Haversian canal, so that's why it's called the Haversian system. We've also got little branches going off in between those canals, and they're called perforating or Fortman's canal. Now that's definitely a German name. And you can see that around the osteons there's also other little lamellae that kind of fill up the gaps and also are more organized like that in the outer part of the compact bone. So the compact bone again is the OCD part of the bone. And then when we look at the spongy bone, that's more like a messy bit. So we don't have osteons in the spongy part, we only have the lamellae. And they're not arranged in a very orderly fashion either. They're kind of arranged in those trabeculae, as you can see here, interspersed by nerve and blood vessels, but they don't reach everywhere. So some of the nutrients have to get there through the interstitial tissues. And the biggest difference between the two of them is, like I said, the spongy bone doesn't have osteons, not very organized. So now we look at how does bone form. So during the embryonic or fetal phase in our lives, so when we're still in utero, we actually have a skeleton made up purely of cartilage, of hyaline cartilage. And only by month 3, so pretty much when the fetal stage starts, will we start to develop bone tissue. So bone gets longer and it gets ossified by a process, it's called endochondral ossification. So the process here is what's called endochondral ossification. Now the important thing to know is that bone and cartilage are two different types of tissue. So the cartilage doesn't get mineralized. The cartilage disappears and gets replaced by bone tissue, which eventually gets mineralized. So the initial bone tissue is just, like we said, that non-mineralized matrix, and our osteoblasts, which eventually turn into osteocytes, and we have the calcium phosphate salts getting put down in between the collagen fibers. So to start off with, we get a little bone collar on the outside, and a little primary ossification center starts to appear. So these are already bone cells, osteoblasts, that have come to the scene. And also osteoclasts, because we've got to get rid of some of our cartilage, so that's got to be gobbled up. The next step that we see is that there's more bone forming inside that cartilage, and the cartilage at the epiphyseal area, in the epiphyseal areas, still continues to grow, because remember, we don't just want to replace it with bone tissue now, we still look at something that's growing very fast. The fetus is growing very fast, so the bones need to grow, so that gets achieved by cartilage that will grow. Eventually we obviously need to have blood vessels coming in there, because we need nutrients, and the nerve would come in as well, and spongy bone starts to form. The outside, the more compact bone, also gets thicker, and eventually, and that happens just before birth, we have a secondary ossification center popping up in the epiphyseal areas. Now when we're born, we're basically born with pretty much an ossified diaphysis, but we still have epiphyseal areas that are pretty much almost separate. So that's why we have more bones when we're born, because they need to fuse. So these epiphyseal areas appear almost like separate bone, and only when they're fused up do we call it one single bone. So in childhood, like I said before, when I showed you that other bone where we only had the epiphyseal line, here we still have the cartilage, the epiphyseal plate. So this means that at this plate, bone growth can continue because the cartilage can continue to, the cells, the chondroblasts can continue to multiply. We produce more cartilage, which eventually gets replaced by bone. And that's how our bones continue to grow in length throughout childhood. Now, bone growth usually stops at about 18 years of age in girls and 21 years of age in boys. And then this epiphyseal plate closes off, so the cartilage disappears completely, and we only see the epiphyseal line in the adult. So this type of growth, the endochondral ossification, happens in all long bones. Flat bones, it works slightly differently. It's called intramembranous ossification, and starts off with a fibrous connective tissue and then osteoblasts forming osteoids, so the non-mineralized matrix in the center, and laying down bone cells around the exterior of it. So if you want to look at that, that's on page 218, figure 611, but that's not that important. And even from this, I just want you to remember that we are born with pretty much an ossified diaphysis, but our epiphyses are still cartilage, continue to grow throughout childhood. We have an epiphyseal plate, and that's quite important to know. We talk about that in the clinical area a lot as well. And you can see from the epiphyseal plate how old a child roughly is as well. That's the most important thing to remember from that. And bone growth stops roughly at 18 with girls, 21 with boys. Now, bone growth can still occur in adults if we have more pressure on the bone or more stress on the bone or more load. So, for example, people doing sports or bodybuilding, we might need to increase the strength of our bones by by making it thicker usually. So that usually happens in the shaft area and is called appositional growth. Bone length doesn't really happen anymore in adulthood, and you can see that this is a child's bone because we've got the epiphyseal plate there. This is just pretty much a follow-on from the previous slide showing that the way the epiphyseal plate works is that we have bone forming underneath. So first of all we have cartilage, and that gets replaced by bone, and more cartilage forms, and that way it kind of pushes out and gets longer. And it also starts remodeling so that the shape of the bone stays the same even though it gets longer, so the proportions still stay the same. Now, the opposite of bone growth happens when people are bedridden and they don't use their bone, or you've had a fracture and the bone gets immobilized. So bone gets reabsorbed and loses strength, and that's why we try and mobilize people as quickly as possible, because we don't want that to happen. So the body has two objectives when it comes to bone. On one hand, it wants to make sure that the bones are strong enough to keep with, to deal with the daily forces that the bone encounters. And like I said, that depends on what the individual does. But the other objective is to actually keep the calcium levels in the blood steady within certain parameters. And you can see up here that the range is 9 to 11 milligrams per 100 mils. Why is it so important that we keep the calcium levels in this range? Well, the calcium ions play a vital role in passing on signals from the nerve to the muscle cells, and we will see that in week 9 when we talk about how the muscles work. So it's crucial to have stable calcium levels in the blood. And the body doesn't actually care that much, or that hormonal regulation doesn't actually care that much about whether the bone is stable or not. So if we had severe calcium deficiency, the body would do everything to get the calcium out of the bone so that we've got enough calcium in our blood to serve all our nerve cells and muscle cells. So the hormonal regulation that looks after that, you can see, is a negative feedback loop. So a decrease in calcium levels will cause an increase in the hormone production, and eventually when we reach the level that we want, hormone production will decrease again. Okay, so how does it happen? Like I said, decreased calcium levels in the blood get measured. We have these 4 little parathyroid glands which sit on the inside of our thyroid gland. The thyroid gland is located in the neck around the trachea. You can kind of feel it a bit. It's like this soft little tissue there. Now the parathyroid glands release the parathyroid hormone, or PTH, when those calcium levels drop. PTH doesn't act directly on the osteoclasts because the osteoclasts, their job is to actually degrade the bone matrix and therefore release the calcium into the blood. It does it via a detour. So it stimulates the osteoblasts first by releasing another protein which is similar to a hormone, which is the RANKL. Now the RANKL then acts on the osteoclasts and causes it to gobble up bone tissue and therefore release the calcium into the blood. Now that RANKL is actually important later on when we talk about medication for osteoporosis. The other thing that you might want to know is that vitamin D increases this RANKL stimulation as well. So that increases our calcium levels in the blood, whereas estrogen and testosterone decrease the action of RANKL. So that's why when we don't have enough, or when we don't have estrogen as much anymore after menopause, we basically don't have anything that keeps this guy in check, and that protein will trigger the osteoclasts to degrade bone. So that's why we get osteoporosis. So bone strength, as I said previously, is purely regulated by how the body uses the bones, what sort of forces act on those bones. That determines how thick they are, what the shape is, and how those trabeculae are arranged inside the bone. And that's called Wolff's Law. Another German. This now is bone healing after a fracture, and this is quite an important one to know because we come across fractures a lot in the clinical areas. So starting off, we have a hematoma when we first have that fracture, because the bones, like we said, are highly vascularized, so that blood leaks into the tissue, and the blood clot itself kind of forms a first healing between those bone ends, those 2 bone fragments that are caused by the fracture. So that causes pain and swelling, because remember, we've got nerves here as well, and that's the immediate effect that we have. Then after that, we form what's called a soft callus. So fibroblasts come along and chondroblasts arrive at the site, and they produce fibers, collagen fibers, and they produce also ground substance. And all that happens within a few days. So we have a soft callus kind of connecting the 2 bone ends from the fracture, But this is still very, very fragile. So this is why we need to immobilize that bone, because this is very wobbly and might break apart very, very easily. So at the end of this stage, some calcification occurs, so some mineral salts get put down, and eventually those that connective tissue that got formed here, that soft fibrocartilaginous callus, gets replaced by bone tissue. So osteoblasts rock up and produce bone matrix and produce osteocytes. So the process is pretty much the same as what we saw in endochondral ossification and bone growth. And that can take from a week up to 2 months, depending on how big the bone is and how thick. And then after 2 months up to several months up to a year, remodeling happens. So fine-tuning of how the bone should look like, and that's dependent on how that bone gets used. And eventually the bone will look exactly like it did before the break. You might not even see that there was ever a fracture in that bone. Now, for this to happen smoothly and properly, this requires that the bones are aligned very well. So they need to be close enough to each other and in the right alignment. If one is sort of off, that wouldn't work. It also requires that we immobilize it, so it's got the time to heal and we don't destroy that by moving. And there are some, and it needs good nutrients as well and good blood circulation, obviously, as you can see. So there are some factors that will impede this beautiful bone healing. Smoking is a big one. Older age also plays a role. Diabetes is another one. So it's important to let your patients know that they can help the bone healing. And obviously you need to make sure that they've got enough calcium and other nutrients. These are some type of fractures that we can see. So in general, we have simple fractures, which means they're just like straight through a bone. We have compound fractures where the bone can poke through the skin. And then we have all sorts of different types of fractures where we can have several fragments. That's called comminuted. We have compression fractures, particularly in the vertebral bodies. We can have a spiral fracture, which again is not that good to heal. Like we can see with these two, it'd be pretty difficult to get them into alignment. So in these cases, we might not be able to do that externally, and like we call it a closed reduction of the fracture, so lining up the bones by just manipulating it from the outside. This might need an open reduction, so we might have to insert nails or rods or plates to align and keep the bits in place. Epiphyseal and green stick fractures are typical fractures in childhood. So green stick, the bone doesn't actually break through completely, just parts of it. And you can see here the epiphyseal one where there is a break at the epiphyseal plate and they just slip apart from each other. Whilst children heal quicker, both of these fractures are not that straightforward. We need to make sure that they heal well, that they're aligned well, that there is good blood supply, that doesn't get impeded. And then we can have depressed fractures, which is very often the case with the skull, where the bones get pushed inwards. And you can imagine that this bone fragment poking inwards is not very good for the brain. So fractures can really have an impact on a lot of other organs and body structures as well. This is a table just showing you some important terminology or some common terminology that is used in bones and on the spine. And I think some of them you really should try and memorize. So some important ones are the crest, particularly talking about the iliac crest, the trochanter of the femur, the trochanter major here, very important structure. that we use as a landmark for finding an injection site for intramuscular injections. Head is another one, so particularly the head of the femur, the head of the humerus, head of the femur, or called neck of the femur, because the head sits on a neck. A very common fracture in the elderly, or we call it a NOF. Facet joints, very important in particularly the vertebrae and the spinal column. You might have heard of facet joint injections, that's where they are done. Foramen, so we've got the big foramen magnum at the base of the skull, and that's where the brain is connected to our spinal cord, and the spinal cord leaves or comes off the brain and goes all the way down our spinal column. Notch, for example, the sternal notch, again another landmark, so that's another important word to know. So this is now an overview of the skeleton. We've got the anterior view here, and these really are the bone names that you should know. I don't think you need to know every single carpal, and I don't think you need to know every single tarsal bone, but you need to know all the other bones. You don't necessarily need all the different structures on them either. If you work in orthopedics, then you might want to go down that path, but for the general nurse, just knowing the names of the bones is the most important thing. And then we've got our posterior view here, and we will look at 3 structures in more detail. So our pelvis, our spinal column, and the thoracic cage, because like I said, there are landmarks that we need to know, and because a lot of the terminology also then gets reflected in either muscles or some other organs. Now this here is the skull at first, and I just wanted to put that up as well because some of those bones, the names, like I said before, they can then inform names for other structures. In this particular instance, it's the brain, so we have like a frontal lobe and a parietal lobe and a temporal lobe of the brain, and that refers, and an occipital lobe, and that refers to those bones. So those are quite important to know: frontal, parietal, occipital, and temporal. You already know that that's your mandible and your maxilla. Then we've got this funny bone here, the zygomatic bone, the nasal bone, which then has cartilage at the end here. Don't worry too much about those little ones like the ethmoid and the lacrimal bone. Couple of structures that you might want to remember is particularly in the temporal bone. We've got the acoustic meatus, so this is where our ear sits, and that's how the sound travels into the skull, so the inner ear. And this has also got some funny processes, so the mastoid and the styloid process, and likewise our mandible also has a condylar and a coronoid process, and these things sometimes pop up with fractures or in other in another context. So now here comes our spinal cord, our spinal column with the spinal cord inside it. So the spinal column, one of the important structures of our skeleton. We have 7 cervical, 12 thoracic, and 5 lumbar vertebrae. Apparently you can remember it by breakfast at 7, lunch at 12, and dinner at 5. No, dinner at 5. I never get dinner at 5. The 2 top ones here, the cervical bones, are the atlas and the axis, and they have got quite specific shapes. So the atlas, a very flat bone, pretty much just a ring, is where our skull rests on top of that, and this provides some movement between the skull and the vertebral column. That is the one that allows us to nod. Whereas the axis, again, a very specific shape, specifically shaped vertebra, has what's called the dents, so it's got that little thing poking up where the atlas rests on, and the atlas can actually rotate on the dents, and that enables you to shake your head. Our thoracic vertebrae, they allow twisting, but they don't allow flexion or extension in the frontal plane. So they don't allow you to bend forward or to bend backwards. That happens in our lumbar spine. So my pet hate is when you see patients sitting up in bed, so the bed head has been raised, the patient's sitting up there, but they've slit down the mattress, and they're actually supposed to bend in their thoracic spine because they're so far down, rather than in their lumbar spine. And that looks terribly uncomfortable. So the thoracic spine is not meant for bending forwards or backwards. Our lumbar spine allows that, and also lateral flexion, which that is kind of impeded in our thoracic spine by the rib cage. And then we've got our sacrum and the coccyx. Now, they always talk about the double S shape, 1, 2, of the spine, so the double S bend. And you can see that they call it cervical curvature or thoracic curvature, either concave to the back or convex to the back. You can also say that this one here is lordosis, kyphosis, lordosis, kyphosis. So that gives a double S bend of our spine. Some other structures, so you can see for stability, our spine has a lot of ligaments, obviously, because otherwise it will just collapse. So the biggest one is the anterior longitudinal ligament, which is attached to the discs, but also the vertebral bodies. We do have a posterior ligament as well, which is only attached to our discs. And then that gets reinforced by the ligamentum flavum, which travels all the way down between the spinous processes of each vertebrae, all along down from the cervical area to the lumbar area. Some other structures we see, this is the body of the vertebra. Then we've got processes, the spinous and the transverse ones. We've got the lamina here, and we've got the, oops, I've just got a blank at the moment. Oh, the pedicle, sorry, this is the pedicle of the spine, of the vertebra. And the pedicles contain the facets, which you can here see the two bottom ones. And they would, superior view, so the two top ones. And they would link up to the next vertebra, the inferior facets. So superior facets and inferior facets join up together. You can see that these are our spinal nerves. They come out through here, which is our intervertebral foramen. So between the vertebrae, they form the intervertebral foramen, and that's where our spinal nerves come out. You can see the disc here as well, so the bone is underneath. And you can see the spinal canal where our spinal cord is located. Just wanted to bring this one up separately again because that shows a prolapsed disc. So the discs are fibrous. They contain a ring on the outside, which is called the annulus fibrosus, and a center, which is kind of pulpy, and it's therefore called the nucleus pulposus. Now, when that annulus fibrosus ruptures, the nucleus can get out, and the whole thing kind of slips and pushes onto our spinal cord, which you can see here in white. So this is an MRI, magnetic resonant image, which shows soft tissues beautifully. Now those discs contain a lot of water as well because they need to buffer the shock, and during the day we lose a bit of water from those, so at the end of the day we're a little bit shorter than in the morning. These are some examples of extreme kyphosis and extreme lordosis. Kyphosis can be caused by osteoporosis, so the vertebral bodies kind of collapse, and that kind of makes that person very bent. During pregnancy, because the kind of tummy pushes out that way, we get more lumbar lordosis. And this is a congenital problem with the spine, where the spine, instead of being straight, has like a bend to one side, and that's called scoliosis. Depending on how bad it is, it might require surgery. So the next skeletal structure that we look at a bit closer is our thoracic cage. Main thing to remember with that, we have 12 ribs. 7 are true ribs, 1, 2, 3, 4, 5, 6, 7, because they kind of connect directly to our sternum. Whereas these guys here, 8, 9, 10, 11, they don't. They kind of connect with the 8, 9, 10, 11, yeah. So they, hang on, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So it's only 10. I counted wrong. So 7 to 10, 8 to 10 connect through just cartilage to basically the 7th. And then 11 and 12 are what's called floating ribs. It's even written here. Now the sternum has 3 main landmarks, so you can see it's got 3 parts: the manubrium, the body of the sternum, and it's got the xiphoid process. We've got the notch up here, which you can palpate very easily, just sliding down your neck, you end up in the notch. Then where the manubrium joins the sternum, you can also palpate that. It's like a little bit of a raised bit that you can feel under the skin. It's the sternal angle, and then where the xiphoid process joins, that's our xiphisternal joint. Now the xiphoid process can remain as a cartilage until probably 40 years of age, but then it usually turns into bone as well. This is a view from the side. So again, you can see your sternum here. You can see the notch and the angle, and you can see what other structures lie behind. So we've got the heart here, and you can see that the apex of the heart is pretty much where your xiphisternal joint is, and you can also see that the bottom third of your sternum is where you should do your CPR compressions, because basically then you compress the heart very nicely. If you were further up, you wouldn't be as effective. You want to get the big chambers of the heart. And you can also see that the jugular notch refers to T2, and our sternal angle to T4, and then the xiphisternal joint to T9. So it helps us to find landmarks on the body. And then we finish off with our pelvis. So again, quite a few landmarks. The iliac crest, which particularly with the anterior superior iliac spine, so that pokey bit, that's the one that you can feel through the skin as well. And you can see the pelvis is made up of 3 main bones. So we've got the ilium, this big one at the top. Then we've got the ischium, which is kind of coming from behind and coming up to here. And then the pubis, which has kind of 2 rami. It's got the superior and the inferior ramus, superior, inferior ramus. Those 2 pubis bones are joined by the pubic symphysis. That was cartilage, remember, elastic cartilage. And you can see also the sacrum is linked up to the iliac bone. So this is our sacroiliac joint, which that often causes pain. So the whole of it is our hip, or our pelvis, and we basically call one of these, so the ilium, pubis and ischium, one hip bone or a coxal bone, and 2 hip bones plus the sacrum form our pelvis. Other structure that it's a little bit difficult to see here, the ischium has a rough area at the back called the ischial tuberosity, which we call sits bones. So that's the area that you can feel when you try and palpate underneath your bottom and find the bone that you sit on. That's our ischial tuberosity. Now those big holes that you can see in the pelvis are usually covered by a lot of very strong ligaments. that have only openings for vessels and nerves, and muscles might go through as well. The pelvic shape is also very important on the size in childbirth, and male and female pelvis look slightly different. So the angle in a male is much steeper. This would be a female pelvis. Okay, so that was the part 1 of our musculoskeletal system for week 7.